السلام عليكم ورحمة الله وبركاته. Good evening, every all. Welcome to Thyroid webinar series that organized by Arab Thyroid Association. The webinar today about thyroid eye disease. Welcome faculty of Dr. Petros Piros and Dr. Ali Zahrani. Firstly, we will start with Dr. Petros Piros. And every questions can you write in question and answer, and we will answer the question at the end of the webinar. Firstly, we will start with Dr. Petros Piros, consultant endocrinologist, Royal Victoria Infirmary, UK, and the topic will be about treating the thyroid eye disease on either side of the Atlantic, the chasm widens. Welcome, Dr. Petros.
Thank you. Thank you very much. And let me just share my screen. The title is a little different to what you announced. Let me bring it up, I hope. Are you able to? Okay. Okay, I hope you can see the screen at full screen and you can hear me okay. And good afternoon to everybody. I'd like to thank the Arab Thyroid Association very much for this invitation. It's a real pleasure and a real honor actually to be sharing this with distinguished guests. So I'm going to talk a little bit about thyroid eye disease, present and future. And instead of an introduction, I'd like to just highlight 5 points which I believe are important and important to bear in mind with what will follow. So the first one is that the epidemiology of thyroid eye disease is changing over the years. And if you look back to the 1960s and reflect as to what is happening up until now, the proportion of patients with thyroid eye disease amongst those with Graves' disease has progressively declined from some 50% to about 20%. And not only has the prevalence declined, but also the severity of those patients that we see in our clinics is less. So this data again show the proportion of patients with severe disease has gone down from about 50% in the 1960s to less than 10% now. The second point is that patients with mild disease, which comprise the majority, usually fare very well. And if we just manage them conservatively in our endocrine clinics, about 60%, the eye disease will resolve completely. And even patients with moderate to severe disease often do get better naturally. Important to keep that in mind. And these are figures and percentages from a variety of studies. So the overall improvement can be as much as 59, 60%, and inactivation up to about 30%. Even proptosis, reduction by 2 or more millimeters, can occur spontaneously in about 15%. And diplopia can get better, not necessarily resolve, but improve in almost a third of patients. The fourth point to make is that the therapeutic landscape is changing. And we now have new drugs that are highly effective, new drugs that can actually reduce proptosis, but the problem is that they are unaffordable. So I think the conventional way of managing thyroid eye disease is going to be with us for a little while. And that makes it even more important that we should think and focus on prevention. My fifth introduction point is the publication of this consensus statement jointly by the European and American Thyroid Associations at the end of last year. And this really has everything you need to know about thyroid eye disease. It includes diagnosis, assessment, as well as management. So over the next 20 minutes or so, what I'd like to do is talk a little bit about activity and severity of thyroid eye disease, I'll touch upon some of the simple measures that are important, and then I'll concentrate on management of different severities of thyroid eye disease. Then I'll go on to touch upon novel therapies, prevention, a few comments about how we organize our services for patients with thyroid eye disease, because I think that is really important, and some conclusions. So, activity. Well, it's often said that you can tell when you see it. So these are examples of patients with active disease, and they're characterized by features of inflammation, so redness and swelling. And in contrast, these are examples of patients with inactive disease. So you can see here, the swelling and the redness is gone, and these patients are left with the chronic, long-standing features, such as lid retraction on the left, squints, as shown in the middle, and proptosis. You can quantify the activity by using the clinical activity score, which has been used very extensively for the last 30 years. This really consists on assessing patients on the basis of whether they have features of acute inflammation, such as pain, redness and swelling of the lids, redness and swelling of the conjunctiva, and redness and swelling of the plica and caruncle. But what is just equally as important, if not more, in trying to suss out whether somebody has active disease is paying attention to the duration of the disease. And as a rule of thumb, patients who've been suffering from thyroid eye disease for less than 9 months are very likely to have active disease. And also pay attention to trend across time. So if you often get from the history a sense that the disease is either getting better or worse. And if you don't have that information, you can just watch patients and assess them 2-3 months apart and then see what the trend is. And then severity really relies on a number of parameters that used to comprise the no-specs classification. So the amount of lid retraction, the amount of soft tissue involvement, exophthalmos, diplopia, corneal involvement, and optic nerve function are the main features of severity. But we also include quality of life as one aspect of severity. And so these are some examples of patients with mild disease, and by and large, in these cases, the impact on daily life, on quality of life, is minor. They usually have one or more features of upper lid retraction, which is mild soft tissue involvement, mild exophthalmos, and patients with mild disease either have no or just intermittent diplopia. And then patients with moderate to severe disease, here is when the quality of life is affected. And they have similar features, but more severe than mild disease. And they may have constant or inconstant diplopia. And in fact, if they have diplopia that is constant or inconstant, that immediately places them in the moderate to severe category. And then sight-threatening thyroid eye disease, the commonest of which, although it's pretty rare, is dysthyroid optic neuropathy. But severe corneal ulceration, threatening perforation is another side of sight-threatening thyroid eye disease, and very rarely globe subluxation. So I'd like to just focus now on what I call TIERS, which is an acronym, a mnemonic, if you like, of some of the relatively simple and cheap measures that we can undertake that seem to influence thyroid eye disease. And first and foremost, smoking is an important risk factor. Rendering patients euthyroid and then maintaining euthyroidism is important. The use of artificial tears that can prevent corneal ulceration is really imperative in cases who have such symptoms. Avoiding radioactive iodine, also important. And for patients with mild thyroid eye disease, evidence exists to suggest that a short course, 6 months of selenium, may be helpful. So just to look at the background for this evidence, there are observational studies showing that current smoking really raises the risk of thyroid eye disease up to threefold. And not only that, but patients who continue to smoke do not respond as well to medical or even surgical treatments. And the good news is that those who manage to quit smoking, those risks decline very rapidly. The evidence about dysthyroidism comes again from some cross-sectional and some prospective studies, but there is generally an association between episodes of dysthyroidism with the risk of thyroid eye disease. In at least one study, the severity of thyroid toxicosis as expressed by the level of T3, the diagnosis of Graves' disease, correlated with the risk of developing thyroid eye disease. And in another study, post-radiation hypothyroidism was a significant risk factor. The evidence about radiation is best illustrated by this large study, which is now nearly 30 years old, from Italy. And the point to point out is that patients treated with radioactive iodine had a small but significantly greater risk of developing thyroid eye disease or progressing than patients treated with methimazole. And the same study also showed that you can use a short course of oral steroids starting immediately after radioactive iodine, which can prevent this increased risk. So overall, if you have patients with thyroid eye disease, radiation is best avoided, but if you have no options, then you can use steroid cover, or if you can afford to wait until the patient becomes inactive, then you can safely give radioactive iodine without any steroid cover. And since we're on the topic of treatment, just to add that there is evidence that thyroidectomy is neutral with regards to the course of thyroid eye disease. So my preference, my personal opinion is that the best way of managing patients with thyroid disease with regard to managing the thyroid is long-term antithyroid drug treatment, provided they can tolerate it and provided that achieves euthyroidism. And there is good evidence accumulating that this approach, treating with long-term antithyroid drugs, is safe and well tolerated. And there's experience that spans up to several decades of use. And just the evidence for artificial tears comes from a variety of sources, and generally patients who have symptoms such as dry eyes, excessive watering, photophobia, really should be treated with eye drops, and that will protect the cornea. And the evidence for selenium comes from a single randomized controlled trial in patients with mild thyroid eye disease of recent onset. And in this study, selenium led to better outcomes, more responses, and fewer patients progressing to moderate to severe disease. So moving on to management of thyroid eye disease from the medical point of view, and starting from the worst end of the spectrum, the mainstay of treatment of optic nerve compression is high-dose steroids. And the common regimen is 0.5 to 1 grams of methylprednisolone intravenously on alternate days for a week, then reevaluate. If the patient is responding, repeat one more cycle, and have your orbital surgeon standing by so that if there is no response or the patient deteriorates in terms of the visual function, they can come in with their orbital decompression. With regards to moderate to severe disease, there are more options. And patients like this, whose main features are soft tissues involvement, apoptosis, clearly the preferred is intravenous steroids, given in weekly doses for 12 weeks. And the kind of response rate you would expect in terms of the features of inflammation responding is about 8%. And then patients like this who have Act's disease, they don't have a lot of proptosis, but they do have motility problems, then the preferred therapy, if you can afford it and if you have access to it, is teprotumumab, because that will deal both with the activity and the double vision, and you expect a response rate of about 70%. If you don't have access to it, the intravenous steroids may help the inflammation, and radiotherapy can also have an effect on motility. But the effect on motility is rather modest, with expected response rates of about 30%. And then patients like this who have active disease and a lot of proptosis, the only drug, the only medical treatment works is teprotumumab. And if you don't have access to it, a response rate of about 77% is expected. If you don't have access to it, then you can use steroids to inactivate the disease, followed by surgical decompression. And the response rate really depends very much on how good your surgeon is. These drugs have been reported to be effective in thyroid eye disease, but I would say that the evidence is rather lacking at the moment. Rituximab, tocilizumab, evidence is a bit conflicting. They tend to be reasonable for inactivation. They may have a role in steroid-resistant patients. And I believe that the evidence for microphenolate is very weak. Just to remind you that even in patients with moderate to severe disease, in selected cases, the best option may be to just wait, particularly in patients who are not severely affected in terms of the quality of life, and perhaps when they are showing already some signs of remission. Just to remind you that the response rates with doing nothing are as shown here in the light blue. And then we're left with patients with mild disease, and again, the mnemonic tears, I think, is worth remembering. And these are the interventions that seem to be important in this patient group. Just to remind you, if you have mild disease, the outlook is good, and nearly 60% will settle down and the disease will not be detectable after a period of 1 to 2 years. So this brings me to novel therapies, and the main one that really has made a difference is teprotumumab. This are the data from 2 randomized controlled trials, overall response rates of 74%, a really respectable reduction in proptosis of 3 millimeters, equivalent to what you'd expect from a good decompression. It seems to be good for diplopia, but the downsides, apart from it being very expensive, is that there are relapses, and they may be as high as 37%. Hearing loss, which was reported initially in this trials to be only affecting 10%, seems to be more prevalent when you look for it and may be more permanent. And the most recent data suggests that it may be effective in terms of reducing proptosis, even in burnt-out disease. So cost, of course, is the other side of this equation. And if we look in terms of US dollars, the course of steroids is peanuts. Rituximab raises the cost significantly. Tocilizumab is about 3 times even more expensive, but this is teprotumumab off the scale. In the US, $350,000 per patient. Now, there are a number of other agents that are undergoing clinical trials, and there's a number of IGF-1 receptor antagonists, similar mechanism to teprotumumab. The anti-neonatal Fc receptor antagonists are also very promising. Anti-interleukin 17A, also promising, and there's a trial on anti-VEGF. And some of these, I have no doubt, will turn out to be just as effective as teprotumumab and will come into the clinical practice, but I expect they will also be very expensive. There are some other agents that are not so novel. They've been around for a while. They're undergoing clinical trials, and I guess if they turn out to be effective, there will be cheaper options. That brings me to the topic of prevention, and prevention is something that's been talked about an awful lot. So since 30-odd years, and it's all talk, but I'm afraid little action, because the evidence from prospective studies is lacking. We know that there are risk factors. We know smoking is important, dysthyroidism, allowing patients to develop corneal exposure, and of course, radioactive iodine. So these are all important risk factors that may have a role in prevention. So can we prevent it? Well, let's think about this. If you think about patients with Graves' disease and you follow them up, most of them will not develop thyroid eye disease. A small proportion will move on to the mild thyroid eye disease, and the majority of those will settle down, the eye disease will disappear. But some will be stuck with having mild disease, and some will progress to moderate to severe. And of those in the moderate to severe category, some will stabilize, some might get a little better, and a few will get worse. And the question really is that if you institute preventive measures, such as those that are summarized by TIERS, early, will it be possible to actually prevent the progression of disease to the more severe forms of the spectrum of severity? Now, I think the case for prevention is made by 2 points. One, that we can easily identify the population at risk. It's all patients with Graves' disease, and you can make it even more focused, because there are other ways of identifying those at highest risk, such as those with a very high TSH receptor antibodies. And I don't have the time to show you the evidence, but there is evidence, and it's also very strong personal impression, that we're not very good in our real life, in our everyday practice, at actually implementing these preventive features. So there's a lot of room for improvement. And finally, I'd like to say just a few things about organizing services for patients with thyroid eye disease. And again, it's my strong impression, my opinion, that patients with moderate to severe and sight-threatening thyroid eye disease are best managed jointly with ophthalmologists who are interested and competent in this condition. And the argument for this is that the assessments that are required for these patients are complicated and specialized, and we're not, as endocrinologists, trained to actually perform them. These days, other ocular comorbidities are very common, and that makes it more complicated. Also, occasionally, there are other diagnoses that disguise as thyroid eye disease, including some serious ones, such as tumors in the orbit. Having a joint clinic means that delivering treatments from the point that the decision is made is actually quicker, and that is important. Overall, I think management is better, and for those of us who've experienced both systems of working in isolation or in joint clinics, the impression is that it is much more enjoyable to work together with colleagues and ophthalmologists, and patients also seem to prefer it. So, my conclusion is that we're in an interesting situation, that we have many more choices about medical treatment, particularly of moderate to severe disease, than ever before, but the cost is becoming a real problem. And secondly, again, to highlight that prevention is better than cure, and that's something we should be focusing on. Thank you very much for your attention.
Thank you, Dr. Petrus, for this elegant and illustrative talk and sticking to the time. Now move to the next with Dr. Ali Zahrani, consultant of immunologist King Faisal Specialist Hospital and Research Center, Kingdom of Saudi Arabia. And the talk is Thyroid Eye Disease Evidence versus Reality.
Thank you very much, Dr. Vada, and thank you very much for the organizers. It's a great pleasure to be here tonight. A special pleasure to share this session with Dr. Petrus Biros, who is a world authority on this subject. I actually feel a bit intimidated talking after him, but I hope my presentation will reinforce what he had just mentioned. Let me see if I can share my screen. So basically, my talk is going to be again about thyroid eye disease. You have just heard the evidence, and hopefully I'll show you some of the reality. Of course, reality should not be much different from evidence, but we will see how things go. The outline of my talk, I'm going to present a case, and I'm going to try to make it interactive with the audience also participating in the discussion and decision and the management of this patient. And as you have just heard, there are some new data on teprotumumab that I will present at the end of the case presentation. These are my disclosures. I participate with Horizon in advisory board and also receive some honoraria from Horizon on talks. Not this one, but at least in the past. We're going to try again interactive discussion. So this is a program that will allow audience to participate. So if you can either scan the code here at the bottom of the slide, or just go to pfox.app and enter the ID number of this presentation, you will be able to participate in some of the questions. I'm going to just wait a few seconds to allow you to do that. So either scan the code or write in your browser on your iPhone or Android, pfox.app, and put the ID number of this meeting. And you will see it again later on. So the patient is a patient of mine. She's a 45-year-old lady who was previously healthy. She presented in December 2020 with palpitations, and she had cardiac evaluation, and she was found to have Wolff-Parkinson-White syndrome and underwent ablation. So that's the story before we saw her in June 2021, when she presented again with recurrent palpitations, but this time also with sweating, heat intolerance, anxiety, tremor, insomnia, weight loss, diarrhea, and irregular menses. And her physician who was looking after her before us did TSH, and it was completely suppressed. So you can see, I think now we are dealing with the symptoms highly suggestive of hyperthyroidism, and indeed TSH is very supportive of that. She was referred to us in June, July 2021. The history is as above, but on specific questions, she reported some eye discomfort, dryness of the eyes also, swelling of the eyelids in the morning, an occasional mild redness of the eyes. She did not have at that time any diplopia or retroorbital pain, no decreased visual acuity. She had she did not have any severe redness, only mild redness, and no tearing. No history of neck swelling, dysphagia, hoarse voice, or choking. She had mild lower limb swelling and generalized itchiness, but no skin rash. Her vast medical history, as I just mentioned, Wolff-Parkinson-White syndrome. She also underwent C-section 2 years before. She started one day before I saw her on propranolol 20 milligram TID and methimazole 20 milligram once daily. Her family history is significant for type 2 diabetes in her parents. Her father also underwent liver transplant for liver cirrhosis. She had irregular menses when I saw her, but previously she was having regular menses, and she had 7 previous pregnancies. The last one was 2 years before cesarean section. She was not on oral contraceptive pills. She's married with 7 children, never smoked, and no history of ethanol intake. Her physical examination showed stable but anxious, tremulous lady who was not pale or jaundiced. As you can see here, she has a bit of tachycardia, her blood pressure on the high side. She is obese with BMI of 35. Eye examination showed mild chemosis, mild swelling of the lower eyelid, a slight redness of the conjunctiva, and no diplopia, normal external ocular movements, The CAS score at that time was 3, so she had mild activity of the disease, and her exophthalmometer showed 70 millimeter on the right and 16 on the left. She had goiter of around 40 gram diffuse with no nodules, no lymphadenopathy, and she had BRUI. She was anxious with hyperreflexia, no skin changes, no pretibial myxedema, and chest and abdomen were normal. So I think you would agree with this history and physical examination that this patient most likely has Graves' disease, and she had mild Graves' ophthalmopathy. And this is quite supported by the lab. You can see here at the bottom that her FT4 was 55 for the normal in our hospital up to 22. Suppressed TSH, T3 is around 3 times the upper limit of normal. And her thyrotropin receptor antibody was elevated at 12. And the rest of her lab, as you can see here, mild leukocytosis, normal hemoglobin, normal platelets, differential is normal. She has normal renal function. Was having some hyperkalemia that we could not understand the reason for it. May be part of the hyperthyroidism. Elevation of alkaline phosphatase mildly, and I already mentioned to you the thyroid function test and the thyrotropin receptor antibody, and she was not pregnant. So we continued methimazole at the same dose and also propranolol. We increased it to 4 times per day. We gave her an appointment in 2 weeks with repeat lab. And here is the first question that I would like to entertain with you. How would you manage the eyes at this stage? You have already heard the physical examination. These are the choices. Doing nothing, it will improve as soon as thyroid function normalizes. Local measures, selenium, low dose oral prednisone, 5 to 10 milligram daily. Give her pulse glucocorticoid, use some of the medication that Dr. Virus mentioned, rituximab or Celset, or refer her to an ophthalmologist. You can choose more than one option here. And again, I want to show you again how to participate. The question would come immediately after this slide. So you can again scan this or put the title in or the address in your browser and choose the ID here. So now you can actually choose one of those answers. I hope we had enough participation. I cannot see if there was enough participation, but let me see. Yeah, people are still voting, so that's great. Yeah, I'll wait a bit. All right, maybe for the sake of time, probably we have enough number to see what the opinion is. We're still getting more and more people voting for this. No. Okay, so here we are. These are the choices. Nothing, 12%, local measures, 80%, selenium, 52%, 4% want to give low-dose prednisone, 4% want to pulse her with steroid. None wants to give immunosuppressive therapy, and only 30% wants the ophthalmologist to see her. And I think at this stage, it would be appropriate for Dr. Piros to comment on these choices and also his opinion.
Yes, thank you, Ali. So it sounds to me as though this patient has active, mild thyroid eye disease, still thyrotoxic. On the plus side, she's not a smoker. She's female, so that these are good prognostic factors, but she has a pretty high TSH receptor antibody. So I think you haven't actually told us anything about her quality of life. Presumably it's not impacting tremendously on her, but she has some surface symptoms. I think I would add eye drops to try and relieve that. and I will consider selenium, and otherwise wait and see what happens. Keep a very close eye on the thyroid function. You don't want her to become hypothyroid. And one other part of the management, which we often forget about, is that they require support, and I mean psychological support. So she needs to be able to understand what's happening to her. I think you should be able to provide some reassurance and reassure her that you'll be keeping a close eye. There is a possibility that the eye disease will get worse, and you'd want to know about it sooner rather than later if symptoms deteriorate.
Good. So I think again, the majority choose local measures, lubricants and eye drops, selenium 52%, and I think we did not include here the psychological support. Let me ask you briefly about referring to an ophthalmologist at this stage. Would you do that, or do you think it's so mild that we can deal with it as endocrinologists?
No, I mean, you've got nothing to lose by referring her to an ophthalmologist, but they're not going to be doing anything at this stage anyway. You can do it. It doesn't do any harm, but I, as a rule, I wouldn't. And the UK situation is that you want to be a little bit cautious, not to overload our ophthalmology colleagues who are very strained as it is. But there's nothing wrong
Okay,
about
great.
ophthalmology.
Very good. So let me tell you what we did. We actually prescribed for her artificial tears. We started selenium, and we referred her to the ophthalmologist. Interestingly, over the next 2 months, she reported significant worsening of her eye symptoms. When she was seen around 2.5 months later by the ophthalmologist, she had diplopia in all gazes. Her right eye was 90 millimeter, left eye was 17. So there has been some progression of her eye ptosis. She had intraocular pressure that was increasing on the upward gaze to 90 and 22. I'm quoting here the examination of the ophthalmologist. So they started her on anti-glaucoma drops, and the ophthalmologist ordered actually CT scan and MRI. I was a bit surprised, but this is what they did. This is the CT scan, and probably can appreciate some thickening or some enlargement of the retroorbital masses, maybe some activity in the orbit. You can see it here also, the superior rectus and the inferior rectus. Dr. Piros, would you like to comment on this, or should I briefly again?
Yeah, I mean, it's as you say, Ali, it's a little unusual for the superior recti complex to be involved, but it can happen in thyroid eye disease. Usually it's the medial and inferior recti. So this patient clearly has involvement of other muscles, the medial recti in particular. So this is consistent with what you have told us.
And this is the MRI, I think, showing the same thing, but in a better resolution. You can see the orbital muscles, and you can see also some activity in the orbit. Dr. Petros just mentioned that it's important to control her hyperthyroidism and not to overdo it, and that's what we actually did. So this is the initial FT4. It was 55. And the T3 was 8.6. This is back in June 2021. So around 3 weeks later, the FT4 was normal and continued to be normal. In fact, at occasions, it was slightly increasing. So you can see that her thyroid function has normalized. It came down. This is the FT4, came down from 55 down to normal level and continue to be a normal level over the next 6 months. Now, in January 2022, this is around 6 months later, and around 4 months after she was seen by the ophthalmologist, and she was seeing the ophthalmologist a couple of times, she came to me in the clinic. She already gained 8 kg. She was Cushingoid. She was euthyroid. The patient was placed on oral prednisone, 50 to 60 milligram daily by the ophthalmologist, and somehow they missed to decrease the dose. And again, this is the reality that we are seeing. So this was a bit annoying to us. At that time, despite this high dose of steroid, she has significant proptosis. In fact, her right eye continued to worsen with right eye measurement of 23, left eye 24 millimeter. The examination of the eye showed red swollen eyelids, periorbital edema, chemosis, moderately congested and red conjunctiva. She had diplopia, she had discomfort on lateral gaze. So her CAS score was quite high, somewhere between 5 to 6. Her visual acuity, however, was normal, and her visual fields seems normal, with only diplopia was interfering with the exam. And again, in an endocrine office, nothing was seen abnormal on her fundal examination. So I think now we could say that this patient has moderately severe disease, and she needs intervention. Dr. Beros, would you like to comment now on her situation? Her thyroid function test, by the way, is absolutely normal, although the FT4 is almost going down.
Yes, thank you, Ali. I agree with you. It is disappointing that she's been treated with oral steroids at such high doses for so long, which clearly have not been very effective. And the evidence is ample that if you are going to use steroids, and I think she has an indication for that, it is far, far better to use pulses of intravenous steroids, which are more effective than oral steroids and associated with fewer side effects, including a less predisposition to developing Cushingoid features. So that's a bit of a letdown.
Thank you.
One other point that I'll make, Ali, just very quickly, is that she now is at very significant risk of developing optic nerve compression. She's progressing, and she's got very significant ocular dysmotility. So it is really worthwhile watching it very carefully, whatever you're doing.
Very good. Okay, so I think this is another point where the audience can also participate. I think Dr. Eros already gave some hints to what to do at this time, but let's look at the choices. So increase oral steroid dose, add Silsit, add Imuran, azathioprine, pulsesteroid, teprotumumab, rituximab, tolisizumab, orbital decompression, or leave all of this to the ophthalmologist. And again, here a chance again for all of you to participate. All right, we'll just get a few more seconds because I can see that people are participating nicely. Okay. Oh, all right. So these are the choices. I'm happy that nobody wants to increase the oral steroid dose. 4% Silsit, 4% azathioprine, pulse steroid, only 32%. Many people are so enthusiastic about Tipro, 40%. None wants to use rituximab, tolisizumab, orbital decompression, 16%, and leave it for the ophthalmologist, 4%. Dr. Beros, what would you do here?
Yeah, well, if I had access to teprotumumab, that would be the treatment of choice, because this patient has got both significant exophthalmos and motility problems. So if you have access to it, that's the treatment of choice.
And if you don't?
And if you don't, I think you have a reasonable chance of achieving something with pulse steroid therapy. But it really depends. I mean, you know, how Cushingoid she is, how well she's tolerated the oral steroids so far, and she may have a very strong opinion herself about continuing with steroids, even in pulses. I would not go for orbital decompression at this stage, although it's been a topic of debate actually, whether in the active phase orbital decompression may have a role, but the evidence is very scanty.
Very good. So let me show you what we did. So actually, we immediately decreased her dose to half, and we tapered it quite quickly. In fact, you would be surprised, she already has some evidence of partial adrenal insufficiency, but we got rid of this. We tapered it very quickly, and we got rid of it over the next 2 months. And we started methylprednisolone 500 milligram weekly. We gave her 12 doses, so a total of around 6 grams. And we were following her closely every week, as suggested. After around 2 weeks, she started to see some improvement. And in 1 month, she reported clear improvement with less diplopia, less inflammation, and the appearance of the eyes was better. She was seen in May 2022. This is around March 2022. And the assessment of the ophthalmologist that she has some exposure keratopathy on the right side with restriction and supra-adduction on the right eye. So she planned bilateral medial wall decompression with rhinology, which actually was done after completing her pulse therapy. So she underwent bilateral medial decompression in July 2022. In October 2022, the eyes are stable. This is the words of the patient. My eyes are much better than before. And actually, the ophthalmologist evaluation, the eyes are quiet, and you can probably understand what she means. Clearly, the inflammation is much better. Proptosis improved to 19 and 18 on the right and left, but she still has diplopia on upper and lateral gaze. She continued to be stable with some activity of the eyes and diplopia, but much better than before. Throughout this period, the thyroid function was well controlled on methimazole 10 to 15 milligrams daily without complications. In April 2023, she was again seen by the ophthalmologist. They said the upper eyelid retraction, there is upper eyelid retraction bilaterally due to tethering of the inferior rectus, and they planned bilateral lateral tersography. She was seen by us in April 2023. This is from our notes. Today, generally doing well, euthyroid, no reportable side effects from methimazole. She has sore throat today, but no symptoms of upper respiratory tract infection, no fever. And on examination, she still has exophthalmos 20 and 21 with the restricted eye movement and on and off diplopia on lateral and upward gaze. And she has mild tearing, but no redness or congestion. So I think that takes me to what to do at this stage. Remember, she received pulse steroid. She received a number of surgical procedures, including medial orbital decompression, tersography. So what should we do at this time? Should we just continue emollients, local measures, resume selenium, give her low-dose oral steroid, consider repeat pulse steroid, teprotumumab, or other immunosuppressive drugs? And again, I will ask the audience to participate in this. Great. So, Beatrice, what do you think we should do at this stage? She is much better than before, but not completely happy. And these are the choices from our respected audience.
Yeah. So Ali, the question, one important question right now is whether her disease is still active or not. And I presume is it still active, do you think?
Mild activity, very mild. I would say the CAS score is maybe around 3.
May I be critical of your ophthalmologist?
Yes, sure. Absolutely. Yeah. We were critical of her many times, so don't worry about one more time.
Yeah. So I think there's an issue here about the timing of the decompression, for which the indication essentially was proptosis. She did not have optic nerve compression. I think I'm right in saying that. So when in that situation, the optimal time to perform decompression is when the disease is completely inactive. The second point is that you don't expect a good proptosis reduction with just a single wall decompression. And I don't think this patient, unfortunately, has had a decent and adequate decompression. The fact that they, subsequent to having a decompression, they felt compelled to do a tarsorrhaphy suggests to me that her proptosis, never mind the figures, but I think in reality, the proptosis continues to be a very significant problem. So with that background, I think right now you have two choices. One is to consider giving a more immunosuppressive treatment if she's still active, or just wait for it to settle down spontaneously. It might take another 6 months or even a year before that happens. And at the end of that, if she's still significantly disfigured by the proptosis, it is worth considering another go at surgical decompression to remove another wall. The other difficulty with the single medial wall decompression is that because everything prolapses in one direction, it is then much more difficult to correct the squint compared to if you do what the ophthalmologists call a balanced or medial and lateral decompression.
Great, thank you so much, Petrus. But I want here to confess and say that we, the endocrinologist and the ophthalmologist, failed to organize a multidisciplinary approach. So while yes, the management from the ophthalmologist we may have some reservation on it, but I must say, and this is the reality, this is part of the reality of presenting this case, that even our hospital is one of probably the best hospital in the region, but we don't have a multidisciplinary service. And that's definitely a fault of us as endocrinologists and ophthalmologists, and maybe the hospital administration. And I don't think this is different from so many hospitals in the region. It's unfortunate that the thyroid eye disease is not paid attention to that much, probably because we don't see many severe cases of thyroid eye disease. For the most part, we deal with mild cases. Hopefully cases like this, and now with the awareness, people will try to do a multidisciplinary approach and multidisciplinary service. Okay, I think that's the case. If you have any more comments, Dr. Petrus, on it?
No, I think you're right. I think a joint approach is really important. And probably the most important aspect of that is to foster and develop a good relationship and trust with the ophthalmologist. The rest follows, but that's really the most important part in my experience.
Excellent, thank you so much. So in the next 10 minutes, I will just review some of the data on this, because honestly, I wanted to use Tibro on this patient, but for logistic issues, we could not get it. I requested it many times, even before using the pulse steroids. And I think it's important to know some of the new data on this agent. So as mentioned by Dr. Piros, the Graves' ophthalmopathy or thyroid eye disease has, in general, two phases: the acute phase, which is an opportunity to treat patients with thyroid eye disease, and then the chronic phase, which is mostly surgical management. But we will see that there are some promising agents that are still effective in the chronic phase. This is what is called the therapeutic window. Of course, therapeutic window is best here in the ideal phase in the first 9 months or so, but it continues to be there even years later, as we will see in our discussion. Teprotumumab is anti-IGF-1 receptor antibodies, and the value of this agent is because IGF-1 receptor and IGF-1 are very important mediators of the thyroid eye disease. As you can see on the sketch, this is the orbital fibroblast, which plays a very important role in greatest ophthalmopathy. And on top of this, there's expression of IGF-1. So when there's an IGF-1 receptor, sorry, and then when IGF-1 receptor, when IGF-1 is secreted by beta cells, sorry, the IGF-1 receptor is expressed on the orbital fibroblast and is bound by IGF-1, stimulate the orbital fibroblast, which induces a lot of inflammation and finally change to either fatty cells or myofibroblast. And of course, this is an oversimplification of the pathogenesis. But the point here is if you interfere with this pathway by, for example, teprotumumab, you break the cycle, you break down the cycle and stop this pathogenic pathway. So Tepro was tested in phase 2 trial initially, and you can see here the patients who were included are patients with thyroid eye disease between 18 to 75 years of age. All of them were in the early phase with less than 9 months since thyroid eye disease started. No prior treatment. The CAS score was 4 or more, which means an active disease. And thyroid function test was reasonable, within 50% of the upper or lower limit of normal. And they were screened, randomized to Tepro or a placebo, 8 infusion every 3 weeks for 24 weeks, so 6 months here. And then they were followed up for the next 48 weeks, so a total of 72 weeks. The primary endpoint in phase 2 was 2 things. One is percentage of participants with more than 2 millimeter reduction in proptosis and more than 2 points, 2 or more points reduction in the clinical activity score. So proptosis and clinical activity score were the primary endpoints at week 24. And as mentioned earlier, 70% roughly of the patients achieved these primary endpoints in the Tepro compared to only around 20% in the placebo. So this is the primary endpoint, the composite endpoints, both of them. And this is the proptosis, which is a major thing. Again, the numbers are almost the same, 71 and 69%. And you can see that this response starts early as 6 weeks and continue to improve over the next weeks. So by 24 weeks, we have a reduction in the proptosis of around 2.5 millimeter. And you can see also the clinical activity score, although it decreases because, again, of the time in the placebo group, but it increases significantly and robustly in the patients who receive Tepro. So the clinical activity score on average at 24 weeks decreased by 3.4 points. The OPTIC is phase 3 trial based on which the FDA approves the drug. If you look at it, it is more or less similar to phase 2 trial. The inclusion criteria is the same. The schedule is the same, 41 patients with Tepro versus 42 with placebo. The only difference here is the primary endpoint focused mainly on proptosis, with a percentage of participants with reduction in proptosis more than 2 millimeters. And you can see similar, again, picture when at 6 weeks, 56% of patients had achieved this reduction in proptosis of more than 2 millimeter and continue to improve. So by the end of the trial at 24 weeks, 83% of patients achieved reduction more than 2 millimeter versus only 10%. And if you combine proptosis and CAS score, you can see a difference of around 71% between Tepro and placebo. So the number needed to treat and to get this benefit is around 1.36, which is significant. You can see also the reduction in proptosis around 2.8 in phase 3 trial. You can see an example of a patient who had very inflamed proptotic eyes at the beginning, and then at 24 weeks, the eyes almost look normal. In phase 2 and phase 3 trial, essentially all the endpoints were met. So proptosis response, which was primary objective, achieved in 83 versus 10% in placebo, quite significant. Overall response rate at 24, 78 versus 7%. CAS score 0 or 1, which means basically no activity, achieved in 60% in Tibro versus only 20% in placebo. And the mean proptosis change through week 24 was in the placebo only around 0.5 millimeter versus around 3 millimeter in the active group. Diplopia responders at 24 weeks were 68% in Tibro versus 30% in the placebo. And the quality of life was much better in around 14% compared to around 4.5%. Not only that the response was there during the treatment, but it was durable. So you can see here the proptosis at week 28, 36, 48, 60, and 70. There was maintenance of this response for the next 48 weeks. Diplopia, the same thing. The composite outcome, proptosis and diplopia, the same thing. And overall quality of life was much better even at 72 weeks. So this is durable. So what's new about this agent? These data were presented in the Endocrine Society meeting that was held in Chicago just around 3 weeks ago. And the basic thing here is this is a phase 4 trial where patients with inactive disease, patients who pass the active stage and are in chronic stage, where we normally think that they can be only managed by surgery. This trial is showing us some interesting data. So if you look again at the inclusion criteria, more than 18 years of age, initial diagnosis of thyroid eye disease must be more than 2 years and less than 10 years. So this is basically the burnt out phase of thyroid eye disease in most cases. Participants could not have had prior orbital irradiation, orbital decompression surgery, or strabismus surgery. The CAS score is very low, less than or equal to 1 in both eyes for at least 1 year prior to screening, or no progression in proptosis of diplopia and no new inflammatory symptoms for at least 1 year. Proptosis increased more than 3 millimeter from patient's baseline or above the normal for race and gender. So the bottom line, this is inactive disease. This could be severe or probably severe, but not active disease. And the patients were randomized to Tibro versus placebo. So this was 2-to-1 randomization, 42 patients in the Tibro versus 20 in the placebo. You can see here very clearly that the duration of thyroid eye disease was on average around 5 years. So this is again a chronic stage, and they were comparable in the placebo and thyroid and the Tibro. And the CAS score was very low in both 0.3 and 0.5. The trial itself was run in a similar way. So 2-to-1, 62 patients, 20 placebo, 42 Tibro, injection given every 3 weeks, a total of 8 injections. So this is basically 21 weeks. And then what happens after? Those who responded were actually followed up to see what will happen. And those who did not respond were offered an additional 8 injections of Tibro. So here in this arm, after 21 weeks, are patients who did not respond or after 8 injection initially. In the follow-up here are patients who declined or who responded nicely. And the primary endpoint is basically the change from baseline in proptosis. Remember, this is a chronic phase. So they want to see the change from baseline in proptosis from here, what will happen to proptosis in those patients. And there are several other secondary endpoints, as you can see here. And then even some other additional study, including pharmacokinetics and immunogenicity. We'll focus basically on the outcome here, the clinical outcome. So you can see that at week 24, whether this is intention to treat or per protocol analysis, there was significant reduction in the proptosis. In the Tibro, on average, minus 2.4 millimeter compared to minus 0.9 millimeter in the placebo. And you can see this is also similar per protocol or even better. This is basically the rate of responders. So 62% responded in the Tibro versus only 25 in the placebo. And again, similar percentages, whether you look at it in the intention to treat analysis or per protocol analysis. In fact, in the per protocol analysis, only 7% in the placebo responded compared to 63%. Based on this trial, there has been adjustment in the indication approved by FDA, basically updating the indication language for Tibro, saying Tibro is indicated for the treatment of thyroid eye disease, regardless of the thyroid eye disease activity or duration. So I think this is one new drug that may change the scene and the management of patients who have chronic eye disease. Clearly, in the active phase, we have so many options as described by Dr. Piros. But I think this is a new thing here that we did not expect, that you can use medical treatment for patients with severe but inactive disease. I want to go back with the last question here. I think maybe we have 2 minutes. On how to manage Graves' disease in this patient. And I think Dr. Piros touched on this, but I want to also to discuss it briefly. So this is a patient who has been now our patient that we just described. She has been on it for 2 years. She has been on methimazole for 2 years, 10 to 15 milligram. Should we continue it? Should we give her radioactive iodine? The fact that now her eyes are less active than before. Should we do thyroidectomy, or should we just stop methimazole and watch? And to help you, let me show you her thyroid function test over the last 2 years. We start from below here. If you remember, she started with 55. And throughout the period, she was mostly euthyroid with occasional mild hyperthyroidism. And I will show you this better in this graph. So we started here. And if you look at FT4, for most part, it was in the normal range. TSH became detectable, but never normalized. And her numbers at this time, sorry, let me go back. Oh, I think now we'll give you a chance to vote again. So let's see what people would choose for the management of Graves' disease at this stage. Okay, so the majority wants to continue methimazole, 11% want to give radioactive iodine, 30% thyroidectomy, and around 12% stop methimazole and see. Dr. Piros, what would you do?
I would continue with methimazole, Ali. I think that's a very sensible approach. Can I just make 1 or 2 additional comments, or
sure, absolutely.
Well, I mean, of course, you can do all the other things. If you give radioactive iodine, again, the real world experience, at least in the UK, is that if you do that, the chance of the patient experiencing an episode of dysthyroidism is of the order of 80% in the 6 months following radioactive iodine. So you don't do very well. It's preventable, but it just happens. And that may be a trigger for more trouble for the thyroid eye disease. Thyroidectomy is fine. It's neutral, but you're subjecting your patient to a major procedure. Stop and watch. Yeah, you can do that, but there is a 50% chance of her relapsing. And if she relapses and becomes thyrotoxic again, that may act as a trigger for reactivation of thyroid eye disease. So for these reasons, I would just, provided that she tolerates methimazole, I would just carry on.
And that's actually what we did, especially if you look at her thyroid function test. She has never normalized her TSH, which indicate that maybe there's still some activity of hyperthyroidism. More importantly, on a couple of occasions when the dose was decreased, she showed him a relapse. She showed activity. So I think it's clear that this patient needs treatment, any of this, but I totally agree. And this is what we are doing with this patient at this time. We are continuing methimazole. Okay, I will stop here, and I'm sorry if we have exceeded time, and the floor is for Dr. Rano. I think we are hopefully on time. Dr. Ghada.
Many thanks, Dr. Ali Zahrani, for this illustrative and practical case presentation and illustrative talk. Actually, I want to ask you about if there is failed intravenous steroid for this case. What the next step for this patient? If we have in developing countries and we have no use for table.
So I will tell you, and then I will ask Dr. Beros, the expert, to comment. Personally, I would love to have Tibro on this patient for two reasons. Number one, she is now more than 2 years, so she has entered the chronic phase. Two, she still has some activity. So I believe that a good choice for her will be Tibro. I am not inclined to pulse her again because the activity is not that much. And the patient is not totally comfortable. She is, of course, very happy compared to the past. She is much, much happier than before. Her husband is not happy because he see that she is still suffering. So if I have the choice, definitely my choice will be Tibro, and I'm trying actually to get it for her, but we have some difficulties, logistic difficulty. Dr. Beros, what would you do if you're in an ideal world?
Yeah, well, in an ideal world, I would agree with you, Ali, that teprotumumab offers many potential gains in this patient. But Dr. Al-Khatib, you brought up a really important point, which is that, you know, all the things that we profess and talk about in thyroid eye disease, such as pulses of intravenous steroids, sometimes are completely impractical. Sometimes patients come from very far away. They couldn't possibly be coming every week to a major center to receive it. And I think this is actually the importance of your organization, the Arab Thyroid Association, to highlight these difficulties that, you know, we're all focused in a very Eurocentric way. But there may be ways of being able to deliver pulse steroid therapy, for instance, in different ways that don't involve people having to attend and travel. On the topic of steroids, you don't want to exceed a cumulative dose of 8 grams because the side effects become significantly prohibitive. So I think in a patient like this, either you just wait, that's probably the best option, or if you can give teprotumumab, you could do that.
My second question is for the patient to continue methimazole or discontinue. As regard if the trap become negative, we should also continue methimazole for this patient, Dr. Petros, or stop?
Yeah, so if the traps are negative, I'm a little puzzled that they have become negative so effectively. And very often in this stage, the continuing suppression of the TSH, as is happening with this patient, usually indicates, as Ali said, that there is some activity. And I think this patient, despite the negative TSH receptor antibodies, is still at very high risk of relapsing, much higher than 50%. So again, it goes back to if this patient is tolerating the methimazole without any difficulty, it's achieving euthyroidism, why rock the boat? Because I think that's what you'd be doing if you stopped methimazole.
Okay.
If I can just add one thing here for the audience, I mean, negative thyrotropin receptor antibody is a very good prognostic factor but I think it is less probably important than when you have already indication that the thyroid is active, like this patient. I mean, with a reduction in her dose from 15 to 10, you can see easily that her FT4 is going up, and frequently we catch her before she goes quite hyperthyroid. So I think the activity, the thyroid function test is telling me more than the thyrotropin receptor antibodies.
There is a big question for Dr. Petros. In the criteria of site-threatening thyroid eye disease, some might urge that dose of 0.5 to 1 gram per kg is considered low, especially when you are tackling the criteria of site-threatening. Any idea of possible being more target in terms of the dose and increasing it?
Sorry, yeah. So your question is about the dose of intravenous steroids in site-threatening optic nerve compression.
Yes, I think that's the question.
No,
Is the dose might be, the dose that you proposed might be low for a site-threatening.
Yeah, so the problem is that there aren't any good randomized studies in patients with optic nerve compression. You can imagine the practical difficulties for recruiting patients for such a study. So it's empirical, and it's the doses that I quoted and I widely used for this indication is a reasonable balance between what you expect to be effective and not reaching that critical cumulative dose of 8 grams, beyond which there are difficulties with risks of hepatic problems and others. So people have, of course, they have used higher doses, but you're taking a risk, and one has to be, prepared to compromise and try to deal the individual. So if you, for instance, if you have a patient who, has completely lost vision, then you may be more inclined to use higher doses of steroids. But I think the key to it is that whatever dose of steroid you use, there are reasonable data that show you only get a good response in about 40% of cases. So you've got to have the option of a decent surgical decompression if the results from your steroids aren't any good or they're suboptimal. And I think, again, the experience from centers that have decent orbital surgeons is that the threshold beyond which you intervene with surgical management is low. So, if you don't get very significant improvement within a week, then you really have to seriously think about the surgical option.
The second question for you, Dr. Petros, from the same doctor, about the finance of use of Tibro. You recommend any drug to replace Tibro? What about your recommendation for the effective drug can replace Tibro from your experience?
Okay, alternatives to teprotumumab? No, at the moment there isn't anything which is nearly as good as teprotumumab. I mean, we have experience with steroids. The steroids are, I think, just as good as inactivating the disease. That's what the evidence suggests. But most patients don't just have inflammation. Most patients also have proptosis and also have motility problems. And teprotumumab is the only agent that can address both. The conventional kind of management is at least a 2-stage sort of a process. You inactivate first with steroids, but usually you end up having to do something else in addition. Now, perhaps in another 6 months, maybe a year or 2, we may have alternatives that are just as good or even better than teprotumumab, but not at the moment.
Another question for you, Dr. Ali, about this case. There is any benefit to make this patient hypothyroid?
Hypo?
Hype, yes.
No, I think that's actually opposite to what is recommended. In fact, one of the proposals is that patients who go hypothyroid tend to have more severe thyroid eye disease. This is one of the, let's put it, the risk factors. Maybe Dr. Biros can comment further on this.
Yeah, no, absolutely. I mean, that's something to be avoided. So both hyper and hypothyroidism are no
Maybe
good.
maybe the one who asked the question is referring to some strategies of block and replace. In other words, giving a higher dose of methimazole to block completely, and also to get some immunosuppressive effect of methimazole at the same time you replace with thyroxine. Is that something that you believe in, Dr. Biros?
Well, it is exactly a matter of belief, Ali, isn't it? Because if you look at all the evidence from several randomized controlled trials, the result in terms of managing the hypothyroidism is that there doesn't seem to be much difference between block and replace. I prefer block and replace because in my hands that seems to be working better, and I can extend the interval between visits because I'm more confident that they will remain euthyroid. But I don't think there is much. And the theoretical additional immunosuppressive effect that you might get from high dose doesn't usually translate to any practical benefit.
Can I ask a question to Dr. Biros here?
Yes.
Two brief questions. One is you were mentioning that the toxicity of pulse steroid increases after 8 grams, which is well known. But is it the same level of risk if I give the patient pulse steroid 1 year ago and then I repeat it today? Is that cumulative dose concept still holding or not? So that's one question. The other question is, for my patient, if I don't have TIPRO, what do you think the effect of external radiotherapy? Although I'm not a big believer in this, but the patient, has some activity and she has also diplopia.
Yeah.
So what do you think about this?
Yeah. So with regards to the toxicity, nobody knows for sure. So we talk about cumulative doses. Is it cumulative for life? And the other part of that question that we don't know is if the patient has received oral steroids, does that count in calculating the cumulative dose? My feeling is, Ali, that the longer the interval between the last time the patient received steroids, the better in terms of reaching that threshold if you have to. But ideally, I don't think you should transpass the 8 grams, thinking about 1, 2, 3, whatever, how many years if the patients have received it, because there probably is a risk that carries over. About external beam radiation, the evidence is that it doesn't do very much to inflammation. It helps to some extent with the motility, so especially the horizontal excursions of muscles. So one of the indications, I would say the absolute indication for radiotherapy is that the patient must have motility problems. If they don't, you're not likely to get any benefit. And the benefit is modest. He expects some improvement in about 30%.
Thank you.
I want to ask Dr. Petros about unilateral eye disease.
Yeah.
What is the management and the follow-up?
Yeah, so it's an odd thing. I mean, it turns out that actually most patients with thyroid eye disease have asymmetrical disease. Completely unilateral is pretty rare. It's less than 5%. It tends to be associated with euthyroid or hypothyroid eye disease, but also, of course, with Graves' disease. And the lesson that we've learned over the years is that if you see unilateral disease, be prepared, because the other eye is going to go in due course. It might take 1 year or 6 months, but usually it follows. So we tend to hang on to these patients, not discharge them once the unilateral disease has settled down. The management is pretty much the same as bilateral, but unilateral disease for equivalent levels of severity to bilateral disease is aesthetically more disabling. So funny enough, if you just have one eye popping out, even though it might not be more than 2-3 millimeters than the other, that's much more disabling in the way people look than having both eyes pop out to the same extent. So I think we ought to be kind of more sensitive and aware of that. And our practice has been to have a lower threshold for offering rehabilitative surgery to such patients in terms of offering a decompression or other procedures to improve their appearance.
Okay. Dr. Ali, you face and experience cases of euthyroid TRAB negative thyroid eye disease. What is the confirmatory test for thyroid eye disease in this case, other than TRAB?
I think the important thing is to exclude other potential serious causes like retroorbital tumors and other pathologies, rare inflammation. But I think the diagnosis is based on clinical grounds, imaging study again to make sure that you're not missing something deep in the orbit. Usually, I think it is rare. Maybe Dr. Peros can comment further on this. It's very rare to have significant eye disease in the absence of some autoimmunity. If not TRAB, frequently you will find that anti-TPO antibody and anti-thyroglobulin antibody positive. So I think the diagnosis is clinical, supported by imaging, and that's what I believe is the case. Dr. Peros, you have comments on this?
Yeah, I entirely agree, Ali. And when it is truly completely unilateral, imaging is really compulsory for those reasons that you mentioned, Ali. And what you're looking for in imaging is absence of an alternative diagnosis and some of the hallmarks that confirm thyroid eye disease. So on imaging, almost always you will find some enlargement of the muscles on the contralateral, the apparently normal side, in the usual distribution, affecting mainly the inferior medial recti, sparing the insertions of the muscles.
I must mention two patients that I remember now, or a few patients, but one patient, he had Cushing's syndrome. He has significant proptosis, or significant, I mean, if you look at him, you would think that he has Graves of Kamal, but in reality, he has only retroorbital fat as part of redistribution of fat and obesity. And then also a couple of patients with acromegaly where, again, the eyes are protruding to some extent, but you don't see much of activity. I mean, you don't see inflammation. You see only pseudoproptosis, I should call it. So these are things to be considered, but usually the patient has a clear diagnosis. I mean, the Cushing patient that I mentioned is clearly, I mean, he's frankly Cushingoid. There is no mistake about it. And then the acromegaly is the same thing. So,
yeah, you're absolutely right. I mean, it's one of the not common but certainly well recognized features of Cushing's to develop proptosis. And there are rare anecdotes that are fascinating. We've had patients with Cushing's who the eye disease predated the Cushing's, and the eye disease became rapidly better as the patient developed Cushing's, kind of treated himself endogenously.
Okay, Dr. Petrus, you prefer oral or pulse therapy of steroid, and how many cycles of pulse steroid can be repeated to reach the optimal response for the patient?
Yeah, so there is ample evidence from many different randomized studies from different places that concur that pulses of intravenous steroids are more effective and associated with fewer side effects. And, you know, personally, I have not used oral steroids for thyroid eye disease for many, many years. In terms of the optimal regimen, there have been studies that have looked at that, and the optimal for moderate to severe disease is, as Ali described, 500 milligrams weekly for 6 weeks, and then half that dose, 250, for another 6 weeks.
The last question for Dr. Ali about there is any role of combined treatment pulse steroid with rituximab or other alternative?
No, that question is not for me, for Dr. Piros. This is it. This is a
Sorry,
bit tough.
can I clarify? This is a question about combining steroids
Combining rituximab
Okay.
with pulse steroid.
Yes.
There aren't any data on this. I'm sure people have done it in desperate situations. One of the kind of advantages that people who are proponents of rituximab is that they don't have the side effects of steroids. There is some evidence, although it is not very good, not as extensive as one would like, that rituximab has activity in patients who have failed to respond to steroids. Of course, when giving rituximab or any of the biologics, any of the monoclonals, at the time of infusion, you do give steroids. It's usually just a single dose of 100 milligrams of hydrocortisone. And of course, that's just to take care of the immediate effects of the injection.
There's only one question for me to Dr. Petros as regards the Graves' disease, autoimmune disease, and all guideline does not recommend use of the steroid for autoimmunity and hyperthyroidism, but we use it, steroid therapy in Graves' ophthalmopathy. What is your explanation?
Well, we know that if you do use steroids in somebody with Graves' disease, you're going to get a response in terms of the thyrotoxicosis. You remember it's the standard treatment that we use for a thyrotoxic crisis, and I think it works in different ways. It blocks T4 to T3 conversion, but it probably also stabilizes the thyroid. The effect, though, is short-lived unless you continue with high doses of steroids, and I think that is what is prohibitive, is the side effects of the steroids, and there are no data whether this is, you can give a course and that the autoimmune disease disappears. In fact, the experience that we have from using high-dose steroids in patients with thyroid eye disease is that the thyrotoxicosis continues on its own independent course. So I don't think there is much in the way of mileage. Some of the new drugs that are being developed, like the neonatal Fc receptor antagonists, they reduce autoantibodies, whatever the autoantibodies are. And there are preliminary data that those antibodies can actually deal with the thyrotoxicosis as well as the thyroid eye disease.
There is an elegant question also about development of thyroid eye disease in children at age of 13. There is any need for special care, or there is any difference in management from Graves' ophthalmopathy in children and adults? Yeah,
no, that's a very tricky situation. I mean, the good thing is that thyroid eye disease in children is rare, and in the vast majority, it is mild or moderate to severe. It's exceptional for children to actually develop sight-threatening orbitopathy. And the other good thing is that with just observing and not intervening, the vast majority do very well with time. Now, you don't want to use high-dose steroids, particularly in a teenager who might be going through a growth spurt and all the side effects that are associated with it. I think it is tricky because it's a time, in one's life, being a teenager, that's very difficult, with peers and appearance. So these children, families, I think, need a lot of support and a lot of time and explanation. But the vast majority will do well with conservative measures, concentrating on keeping them in thyroid. And if, by the time they become adults, if they still have remaining sort of aesthetic problems, they can be dealt with adequately with surgical intervention. Again, teprotumumab, I think, is a no-go situation. You don't want to interfere with growth in that age, and there's absolutely no data of safety and efficacy. And also in a special situation like a pregnancy, just monitoring of thyroid function and make the patient euthyroid, there is no role of steroid or anything in pregnancy. Yeah, again, it's very similar to the childhood situation, very tricky. fortunately very rare, and the vast majority get better with time, or at least if you can just wait until they've had the baby, and then you can intervene. Very, very, very rarely you really have to intervene, and we have given high dose steroids in patients with optic neuropathy. And we have decompressed, preferably in the middle trimester.
Thank you, Dr. Petrus, Dr. Ali, for this nice webinar and illustrative talk from both. And thank for all attendee. And I am happy to with you in this webinar. Hope to meeting you in the next webinar organized by Arab Thyroid Association. And thank you.
Thank you, Dr. Vada. Thank you, Petrus.